So I farm so hard, the employees wanna find me, and then wanna hire me. What's 100K to a guy like me? Could you please remind me? Farm so hard, this ain't easy. Working late nights, you best believe me. My grades can only go A's. Never wanna see another B unless I'm Jay-Z. Farm so hard, let's get paid.
This is Morgan Grier.
This is Micaela Hayes, and you're listening to another episode of the Pharm So Hard Ambulatory Care Podcast.
Hi, everyone, and welcome back to the Pharm So Hard Ambulatory Care Podcast. I'm so excited to host Morgan today and interview her for our first episode of our Women's Health series. Today, I'm going to interview Morgan as our content expert on all things hormonal contraception. So she is our subject matter expert today, and she actually designed and implemented a pharmacist-driven service in an OBGYN clinic during residency. If I'm getting that correct, please correct me if I'm wrong, Morgan. So I'd love to hear a little bit more about your experience creating this service within this space, just passion with women's health.
Yeah, so for me, when I was going through pharmacy school, this really kind of became a passion of mine, if you will. I really discovered that we got a lot of questions, even in the community pharmacy setting, about, birth control options, pregnancy, things of that nature. And really remembering that pharmacists are one of the most accessible healthcare professionals out there. So it's really easy for somebody to go up in the community pharmacy setting, especially, and just ask these questions and have a lot of these questions. And pharmacists are perfectly positioned to be able to counsel patients on all of their options when it comes to birth control or breastfeeding or any of these things that come up in women's health. And so I was really inspired to really dive deeper into this space, because not a lot of pharmacists are in this space currently. We have a lot of different specialties and board certifications and tons of different disease states and areas, but women's health has just never been one of those areas, which is kind of ironic because I feel like it's the perfect place for a pharmacist to be. So really looking into women's health and kind of us talking about this series, specifically like talking today about contraception, it's very prevalent. I think it's a hot topic in like politics and just in the media in general, especially with legislation and different things that have happened around the country in the not so recent times. And so for contraception, one of the primary purposes is, of course, to prevent pregnancy. And almost nearly half of all pregnancies in the United States are unintended. And almost 19 million Americans lack access to contraception if that's what they want to have. And so pharmacists are in a great position to provide that access to care. And we'll kind of go into that in the later part of the series when we talk about legislation that actually provides pharmacists the ability to prescribe contraception, because we know that there's sometimes a gap for people to be able to get to places like a primary care provider. So pharmacists and our knowledge in this is going to be super important now and in the future. So I think it's a great topic for us to go ahead and start talking about.
Yeah, that's awesome. I'm really excited to dive into it with you and hear more about just your take on how pharmacists can be utilized so greatly in this space, like you said, for education and just access for healthcare reasons. All right, let's talk about combination hormonal contraceptives. Kind of talk to us about how it works mechanistically and the different components of the estrogen and progestin.
Yeah. So I think it's good to start with this first, because this is probably the most common option that people select, or at least initially select, especially in like adolescence, because this does include like the combination pill. So it works in a couple of different ways, because you do have two components, as you mentioned, the estrogen and the progestin. And so it works by preventing ovulation and follicular development. It also can increase cervical mucus, the thickness of that cervical mucus. And what that primarily does is just inhibiting the sperm's ability to penetrate and go where it wants to go. And so for the purposes of preventing pregnancy, which is the primary reason for using birth control, that's what we're looking at. But we do know, and as we'll discuss a little bit later, birth control can be used for a lot of other different reasons. It could be used for acne. It could be used to manage symptoms of somebody when they're on their cycle. If they have a lot of pain around their menstrual cycle, it could be used for a lot of those different things. And so really, when it comes to selecting the best option for you, it comes around to the different components of what's in the birth control, but then also the dose that's in the birth control. And some people, based on their needs, what they're using it for, acne, menstrual cramps, to completely maybe get away from their cycle as a whole, that could be different on the different doses or number that they need. And of course, we know with anything in medicine, everybody's a little bit different in the varying amounts that they might need. So the two components are estrogen and progestin. So estrogen, the most common generic name that you'll see on the label is going to be ethinyl estradiol. And so again, all of this is a balancing act, because if you have too little of the estrogen in the birth control option that you're looking for, you can have some early spotting in your cycle. If you have too much, you could start to have some side effects like nausea, bloating, headache, maybe have even some hypertension as well. And we'll talk about a little bit later too, the fact that some people don't have estrogen as an option. So estrogen is the main component in our birth controls that could actually increase your risk for things like blood clots. And so in certain people, if they have a history of a blood clot, like a DVT, this is not going to be an option for them. That's going to be a strong contraindication from them having a birth control that contains estrogen in it. There's also people who are higher risk for a blood clot anyway, that by giving them estrogen, it's just going to heighten that risk. So people who smoke, women who are over the age of 35, those are going to only heighten the risk for those patients. On the other side, we have progestin. So progestin, you'll probably see the generic names. The more common ones are norethindrone or like drospirenone. This one is pretty particular. If you have too much, you could have some of the similar symptoms to having too much estrogen, which is like the fatigue, mood changes, headache. But when you look at the progestin, there's a specific thing that we need to pay attention to, which is the androgenic activity of the progestin. And that can vary based on the different progestins that you could see containing in birth control. So there's a specific one called levonorgestrel, and that one has more androgenic activity than maybe some of our other options that you see in different birth controls. And the reason why this one is important, because this is probably the one that causes side effects that women are more concerned about. So things like increasing acne, increasing weight gain, sometimes even things like hyperlipidemia. And so if you have a patient who is more conscious of their weight, they're already struggling with acne, picking a progestin-based product that has more androgenetic activity is probably going to further exacerbate their problems and not be a great choice for them. So again, all of the things that we talk about today, I mean, it's so important to talk with a healthcare professional, and that does include a pharmacist, especially if they feel very comfortable in this topic, is looking through the different options. Because even when you just look at a combination pill, there's so many brands out there, which we'll get to in a second. They all have different components and different estrogen types and different progestin types, and that can all kind of play into what's going to be the better option for you versus another.
Let's go into the different types of hormonal contraception with contraception, talking about the pills, talking about patches, and then rings. And also, what do you do when a patient comes to you and says they're having side effects from hormonal contraception? Say they're having a lot of nausea or they're having headaches. What's your go-to answer or education for them?
Yeah. So I think that's a great question, because it's a little bit easier when you look at like the combination pill, because when you look at options that we'll discuss, like the patch or maybe even the ring, those are kind of set in stone doses and they only really come in those one doses. So this is more particularly for somebody who's on the combination pill where they have variable doses. So when you look at a combination pill, they can come in a variety of doses. So the estrogen can be anywhere from, let's say, like 10 micrograms to up to 50 micrograms for some patients, if that's what they require. So the same thing with the progestin. And so it's kind of what I talked about earlier when you're kind of balancing the components. So if somebody's having, nausea, bloating, etc., they might be having too much of the doses of the balance that we just talked about. So maybe picking an option, let's say that same brand doesn't offer like a lower strength, maybe a different option or a completely different brand that does offer that would be a better option for them. So it's all about kind of balancing that. And then the same thing for the opposite. Maybe they're getting too little of, let's say, estrogen and they're having breakthrough bleeding and they need a little bit more estrogen. So then there might be other products that offer more of that. So likely you're not going to stay with like the same brand and get those different doses, but there are different brands that offer different doses, and it'll just kind of be about selecting which one is going to work the best for you based on what you need. And so when we talk about the combination pill, that's just the first one that a lot of people get started on, especially girls in their adolescence. It's just easy. It's a daily pill. But some people find that annoying to have to just take a pill every single day and remember that, especially if you're a girl in your adolescence. But this is where a lot of girls get started on it, not even for, pregnancy prevention reasons, but it's mostly for getting rid of like acne or regulating their cycle when they're that young because they're struggling with regulating their cycle or even menstrual cramps that come with their cycle. So that's the initial reason a lot of girls even get started on contraception in the first place. But primarily for pregnancy prevention, it's about 91% effective with perfect use. And so we kind of have to put that out there with perfect use is because, not everybody is as adherent as they would like to be or as we would want them to be. So, realizing that effectiveness can go down if you're not perfectly using it. And that applies to all the methods that we'll kind of talk about today. But it's a once a day pill. And the interesting thing about the pill is you can change your cycle a little bit and do it in phases, or even extend your cycle or shorten your cycle, which is kind of interesting because some people want to completely get rid of their period as a whole. And everybody can do that in a couple of different ways. So one of the ways is changing the actual components of the pills throughout your cycle. So there's monophasic, biphasic, triphasic, or quadphasic. And really all that means is most people use a monophasic type of birth control, which means you get the same amount of estrogen and progestin in every single pill. You usually have like 3 weeks worth of your active pills, if you will, and then 1 week where you have either iron pills, because we know there's a lot of blood loss during people's cycles. So some people need iron supplements during their cycle to help with that. And then sometimes they're just placebo, like sugar or water pills, if you will. So that's usually what most people are on because it's easier to kind of adjust the doses of those hormones if people are having side effects from it. However, there are options like biphasic, tri, or quadphasic, which all that means is that every single pill is actually not going to have the same amount of estrogen and progestin in it. So as you move through your cycle, those doses are going to differ as you go through, which is kind of interesting that you could take one pill and it has one dose of something, and then the pill you take the next day is going to have different. But the purpose of why some people might select this option is it's supposed to mimic like the natural fluctuation of these hormones through your cycle as you naturally would in your body anyways. And so some examples of this are like low estrin or orthotricycline. I've had a lot of friends or people I know who have been on those options. And so the only caveat with that, again, it's difficult to change the doses and manipulate because it's a different dose every single day. And then, as I mentioned, some people, they can extend their cycle, shorten their cycle. So some people just want to get rid of their menstrual cycle altogether. They're like, I don't want to do this at all, which is completely understandable. So you could actually go from, those 3 weeks of active pills and then just go straight into another pack and do it that way. Some people like the peace of mind of just having that week off and, either taking the iron pills for necessity or just having the week off to know that they're having their cycle regularly and promoting that process. And so it's really, again, about what's best for each individual patient and selecting the option that's going to be best for them. Our other combination options that we have in this category would be the patches and then also the ring. So both of these are also probably about 91% effective, perfect. Again, it still relies on the patient to be able to place or insert and remove them as appropriate. So for the patches, you can put it a lot of different places. I feel like the patches aren't given enough credit. I don't see them used a lot. It's usually kind of like the pills are the first line, but I don't see the patches used a lot. But it's you do 3 weeks on and then you do 1 week off. Very similar. One thing about the patches that I don't feel like is talked about enough, especially even in pharmacy, which is weird, is it's technically not recommended in women who are over 90 kilos. So about like 198 pounds because of effectiveness reasons. And we talk about weight a lot with some of these agents in women's health, especially like emergency contraception, which we'll talk about in a different episode. But I feel like that's not talked about enough. And I didn't know it for a really long time until I found out. And I was like, wait, if you're over basically 200 pounds, like this is not going to be an option for you. The other weird thing about the patch is that it has about 35 micrograms of estrogen in it, which is similar to some of our combination pill options. However, there's a very distinct warning on the label for the patches that patients will get 60% more estrogen than the pill version that has the same amount of estrogen, which obviously that increased exposure could increase your risk for blood clots. So again, especially if somebody's higher risk, they smoke, high blood pressure, they're over 35, this definitely might not be a good option for them. And that has to do with it being like a transdermal product versus it being like an oral product, like the pill. But I just find that so interesting that you can get 35 micrograms in a patch and 35 micrograms in a pill, but you're going to get significantly more exposure in a patch form. So that's definitely a big warning for patients to be aware of. And then lastly, we have the ring, commonly known as NuvaRing. This is very similar. You insert it for 3 weeks and then you remove it for 1 week and have your period. And then normally you start a new ring. And then if you're ever been in a community pharmacy, I think this is the funny part. I remember when I first started, I was like, where is this? I don't know where this is. I can't find it on the shelf. It's in the fridge. That's why. So that's kind of a fun fact about it. If you've never worked at community pharmacies, that it's stored in the fridge. And then once it's removed from the fridge, it can last for about 4 months at room temperature. But typically it's kept in the fridge, kind of like insulin until you're ready to use it. Just kind of keep it in the fridge just to be safe. I did have a fun story for this one. I had a friend when I was in college and she was telling me this as I was going through school. And she was telling me this because she knew better at this point. And she thought I would find it hilarious, which I did, where she was using this as a primary prevention for pregnancy. And she said that she didn't like the way that it felt when she engaged in activity, and neither did her partner. And so she would take it out during the activity and then afterwards just put it back in. And I was like, girl, that's defeating the whole purpose of why we're doing this. So it's, again, just a great reminder of like counseling points where you feel like, oh, that's maybe self-explanatory. And then you meet a patient where that's definitely a reason why you can never just assume that anything is self-explanatory. So I always found that story very, very funny. So counseling patients, of course, that it needs to stay in place unless you are removing it for cycle purposes. And then if it ever was to fall out or anything like that, just wash it with water and then you can reinsert, of course. One of my favorite things is there's actually a year-long version of the NuvaRing. And I did a project on this when I was in pharmacy school because I found it so fascinating. So it's called Anovera. And it's exactly like it sounds. It's just a year-long NuvaRing. So you put it in for 3 weeks the same way you would a NuvaRing, remove it for 1 week, but then you don't just like throw it away and get a new one. You put the same one like back in, and it's kind of chaotic. It comes with like a carrying case and it's like a little storage thing. So I always found that like really interesting that it was just like, oh, I'm going to just like carry it around with me in a little case. But yeah, there is a year-long option. You don't see it a lot. I would assume insurances don't want to cover that as opposed to like the NuvaRing. That probably is a little bit cheaper, but fun fact, it is an option to have a year-long NuvaRing.
That's pretty cool. What do you think about patches like in the summertime with water exposure and things like that?
So typically the recommendation for that is that as long as you're not like submerged in water for more than like 30 minutes, it's typically okay. I know a lot of people are just genuinely cautious about like fully submerging themselves, like even with like CGMs for diabetes, like people are concerned about like fully submerging themselves anyways. So they typically try to pick a location if they know it's the summer months and they're going to go swimming, that it's not going to be as easily exposed. So they might pick like the upper shoulder or like their upper arm for the times where they know they might be going into the water, especially on their lower half.
Nice. That's awesome. That's definitely something that came to mind. I'm like, yeah, patch would be great. I don't have to remember to take it. I don't have to insert anything, but like, I don't want to have to worry about water exposure in the summer. I go outside a lot. I'm sweating. I'm like, I don't trust that would be a great option. So that's just the first concern that I'm to in my mind. So thinking of what patients might ask. Awesome. Do you have any last minute things regarding the different options or like kind of things to think about or tying everything together with what's the best option for patients in patient specific scenarios?
Yeah, I mean, so for the patches, essentially anybody who doesn't want a lot of estrogen or maybe doesn't need a lot of estrogen may not be the best option because you're going to maybe get more exposure from that than like a pill or versus the NuvaRing. The NuvaRing doesn't actually have a lot of estrogen in it at all. I don't remember exactly the number that they have, but it doesn't have a lot. So again, it's kind of playing around. Again, the reason why the pill is more common is one, it's easy just to take a daily pill, but I think you also have a lot more flexibility and manipulation of the dose if a patient needs different doses dependent upon like what they're looking for or side effects that they're having versus the patch and the NuvaRing. They're kind of set in stone. You can't really change them. So that's why some people, they try those options and then it's kind of like, oh, that just doesn't work for me flat out. Whereas the pill, you can try different brands and try different things because you are able to be more flexible with that.
That's awesome. Great information. All right, now let's talk about progestin-only contraception, and let's cover, I guess, the mechanism of action and mini pills and injections.
Yeah. So the mechanism of action is going to be pretty similar to the combination because the combination has progestin in it. So some of the mechanisms are going to be pretty similar. So the key thing here is it technically can prevent ovulation, but it's pretty inconsistent amongst women. Everybody's a little bit different. So specifically with the pill, it's only about 50% of women actually prevent ovulation. The other 50% are still ovulating while they're on the pill. It's a little bit more consistent with some of the other options that we'll talk about, like the injection or the IUDs. But it also does, similarly to the combination, increase the thickness of cervical mucus. And then the one thing that this does that maybe the combination doesn't do as well is it actually thins the endometrial lining as well. So we'll kind of start with oral again. That is commonly known as the mini pill, is the progestin-only version of the pill. Similar to combination, it's 91% effective with perfect use if you take it the way that you're supposed to. But the main difference when we come to talk about like timing of a mini pill versus a combination pill is that it has to be taken at the same time every day. And it's a lot more closed of a window. You have about like 3 hours that you can work with if it's not like the same exact time every day. So if you pick like 9 a.m. as like your time, you have maybe till about noon before it would really be considered like a fully missed dose with the mini pill. So you have a lot closer of a window. So again, just counseling patients as an option for this is important. You know, if they're having a history of not being adherent with their medications, or they don't foresee, if you're selecting this as their very first option, that they're going to be able to remember to do this every single day, especially in like adolescent years. Again, we talk about the pill being a common first option for girls when they're younger. I just think about like myself, even in high school, like with all my activities, like after school and stuff like that, like I don't even know if I consistently could be home at the same time every single day. And so just talking through those things and the realisticness of those things happening. But the cool thing about the progestin-only mini pill is that it's taken continuously. So if this is a patient who wants to maybe completely get rid of their period, or they have a lot of heavy bleeding, so they want to completely get rid of it, this could be a good option that they're interested in, because it over time can make people have some maybe amenorrhea or completely get rid of them having their period to begin with. The only caveat to that is it can cause some like unpredictable and irregular bleeding, because it's trying to prevent your full cycle from happening. So that can, in the interim, as you're getting used to it in the first initial months, cause some irregular bleeding. And this is also a fun area because this is where the FDA just approved the over-the-counter birth control for the first time. And so that's called O-pill. And the reason why the first over-the-counter birth control was a progestin-only birth control option is because of that risk for patients who are not a good candidate for estrogen having just over-the-counter access to that. So I thought that was the perfect way to go if we're going to do over-the-counter birth control, picking an option that doesn't contain estrogen in it, because sometimes patients just might not be aware that that's a risk factor for them, or what the risk factors even are. And so I thought that was really cool that, you know, we have an over-the-counter birth control option now. It's still about like $50 a month because, you know, you're buying it over the counter. It's not being processed through insurance. One of my initial concerns with it was, if you're on a progestin birth control now, like through a prescription or on your insurance, are they going to just like stop covering this? So far, no, but that would be a concern because a lot of insurances, they won't cover anything that's considered like over the counter. So will we reach a day where maybe that's a thing? I don't know. I hope not. But, you know, I'm glad that it's at least increasing access for patients who might be able to get it if they can, you know, afford $50 a month for their pack.
Yeah, that is definitely a little bit more expensive than I would want to pay for birth control personally. Yeah. And then I thought of to note myself to ask you, what do you think about that progestin-only contraceptions and the endometrial lining? Is there any kind of concerns with that for overall health rather than doing something that doesn't do that? Or is there not a lot of data? What are your thoughts?
So not necessarily. I think that this is just also, it's temporary, right? Like it's not like permanent. So once you're no longer taking the contraception, your endometrial lining should return to normal. So this is primarily just for the purposes of preventing pregnancy and, you know, having the mechanism work in a way that's going to prevent, you know, sperm from getting the way that they want or implantation from actually happening from a pregnancy.
Awesome. Now, do you want to jump into injections like the Depo-Provera?
Yeah, Depo. Depo, it's not used a lot, I would say. I know in my clinical practice now, I think we have 2 patients in our entire clinic that I know are on it. And of the patients that I know are on it, they're patients who are nonverbal and maybe have some developmental issues. And so this is used not for like pregnancy prevention reasons, but more for controlling somebody's cycle or maybe completely getting rid of their cycle to begin with. But Depo, it's a little bit more effective. It's about 94% with perfect use. And so that's, again, you know, you're not taking a daily oral pill, but it is about coming in and getting your injections on time, not being late, scheduling things around like vacations or stuff like that. And so that could be maybe a little bit problematic for some patients. It comes in both an IM and a sub-Q formulation, but it's important to like pay attention because there's 2 different products for it, whichever you're giving, IM or sub-Q, and the doses are a little bit different. So that's important to pay attention to if you're in the clinic space and making sure like the right product was ordered or the right product was pulled before we're giving it to a patient in clinic, because they do differ a little bit. But essentially you use this about every 3 months, which is nice, again, for somebody to have an option, but they don't have to, you know, take something every single day. It's just kind of naturally working without thinking about it. But you do have to be proactive and planning your appointments, making sure you're being consistent with your appointments. One of the negative things about the Depo is it actually can cause weight gain. And I know that's a common thing that a lot of women talk about on birth controls on just a universal level is it's going to make me gain weight. And the Depo actually will. Like we have good data to say every year that you're on it, you're going to gain probably about a kilo, so 2.2 pounds. Probably over the next 5 years if you're on it for about 5 years. So that's something to be upfront with patients about if they're already maybe struggling with their weight or they're weight conscious, being upfront and saying that this really is a likely thing that you might experience. With our combination options, you might have something like bloating and then like water retention. And so that obviously will make you feel like you're bigger and maybe add inadvertently some pounds to the scale, but we actually do have data that Depo over time can cause a little bit of weight gain. And then there's some other weird things about Depo, which I think is why it's maybe not as common of an option. And so it can possibly lead to some bone density loss. And so the CDC actually recommends around like 2 years on the Depo, you start to consider other options just because your risk over 2 years starts to increase of having that bone density loss. However, they have done a lot of research and evaluation to say if this is the only option for a patient, the benefit still outweighs the risk. However, to continuously evaluate if this still over the 2-year time period is going to be the best option for a patient. So just continuing to evaluate that. And then if a patient is wanting to maybe get pregnant in the near future, fertility is something to consider here because this is one of our only options where if you start the Depo and then you decide, oh, I want to start a family and I do want to get pregnant, it does have a pretty prolonged return to your fertility. And it's about like 10 months. So almost an entire year before you can maybe start actually trying to have a family. So this is maybe a better option for somebody who is like, oh, I don't see myself, having a family or trying to get pregnant for at least, the next couple of years, because then, once you do decide that you want to maybe pursue that, you're going to have a pretty prolonged period of time before your fertility kind of returns to baseline from before you started the depot shot.
That's really, really great counseling points and driving those things home. Great information, Morgan. All right, now let's talk about options for contraception, really, that require medical procedures. Talk to us about that.
Yeah. So our two options would really be like our implants and our IUDs. And so I'll start with the implant, more commonly known as Nexplanon. You probably saw that like commercial of Vanessa Hudgens being like, I wear Nexplanon. And she's like holding up her arm in like this muscle fashion. It was very dramatic. But these are our options that are probably the most effective. So they're about 99% effective to have this option. So for the Nexplanon, I personally am scared of Nexplanon. I have just heard so many horror stories of insertions and removals of the Nexplanon going wrong. So they last about 3 years, which also is a long time, but it's kind of a short amount of time for having to have something like surgically implanted and removed in your arm that consistently. 3 years sounds like a long time, but to have it done over and over and over, I don't know. For me, it just seems a bit much. And so one of the more recent horror stories I heard was I work with a nurse and her daughter had the Nexplanon and she had it for 3 years, was going to get it removed and then another one reinserted. And they went to remove the Nexplanon, and as they removed it, it broke in half. And that is just so scary to me. And so they had to like, I don't want to say like dig around to find it because that's a bit dramatic, but like they had to obviously like open up the incision a bit more than they planned to, and then like go and get the second half like out of her arm. And it also was just weird when I was in college and I had friends who maybe had this option that you could literally like, they would like show it to you as like a party trick. They would like put their like finger on their arm and show you how it wiggles and you can like feel it and see it. And that just like personally always grossed me out. But if you love Nexplanon, like I love that for you. But for me, it always creeps me out in a lot of different ways. But similar to the other progestin options that we have, it can cause amenorrhea. So completely getting rid of your period, if that's something that is really a great thing for you. Some people don't like that, but for a lot of women, they're like, yeah, take it away. I don't want it. So this could be an option if that's what you want. But it could, again, like the progestin-only pill, cause like irregular bleeding or sporadic bleeding. So that's just something to be aware of. But yeah, the Nexplanon personally scares me, and I don't think I would ever personally go for the Nexplanon. No. Okay. So IUDs are so interesting to me. I think they're one of the greatest advancements in women's health and women's contraception. It's just, I remember like hearing more about IUDs for the first time. I just find them so interesting. I find them interesting because especially the hormonal one, we'll talk about the non-hormonal option in a second, but the hormonal one, like it has the hormones, right, that do all the things that we talked about progestin-only options doing, but it also just mechanistically, like where it sits, prevents pregnancy that way. And I just find that so funny that it's not only like chemically, but also mechanistically like blocking any like sperm from going where it wants to go. I just find that so fun, the little like T. It's probably one of our most effective options, but it can be painful for some women. I think that's the reason why a lot of women maybe avoid this option, especially for a long period of time, is that it can be painful. And it's so different. You will talk to some people and they were like, oh, it felt like getting a pap smear, or, oh, it just felt like a bad period cramp. And then there's other people that were like, I was fighting for my life. I didn't know if I was going to make it. And there's a couple of reasons why, and we'll kind of talk about what that means as far as like selecting an agent, because some agents can actually be more painful than others, depending upon which one you choose. But I think Patients who have had children before, it's maybe a little bit easier because, you know, their cervix has been stretched. They've had those experiences before, whereas compared to patients who have never had children before, that might be a little bit more painful because they've never experienced, other than maybe a pap smear, a foreign body being in that area before. So that can play into maybe whether an IUD insertion process could be more painful for a patient versus another. But it also comes down to the selected IUD that you get. So I didn't know this for a long time, and I found this out when I was clinically practicing in residency, is there are different strength options for the IUD. So we'll start with like Mirena. Mirena is the one that most people know the brand name kind of like off the tongue. And then it has a generic version, if you will, called Liletta. But both of them have about 52 milligrams of the progestin in it. And so it's milligrams, not micrograms, because remember, this is like a long-term thing. So it's releasing over time. So it can be kind of confusing, like, why is this milligrams versus micrograms? But that's why. But with that, this is the highest strength available. So Mirena and Liletta have 52 milligrams of the agent in it, but with the increase in strength comes an increase in physical size. And so the size of it is probably about 32 millimeters on like the longest part of the physical IUD. Whereas you compare to like Skylena or Skyla, they have about like 14 to maybe like 20 milligrams of the actual hormone. But the physical size is only about like 30 millimeters. And you say, oh, well, that's only like 30 versus 32. But in that area, you know, that can make or break somebody's comfort level. And so if you select a bigger option, which is the option that has more of the actual active ingredient in it, which you might actually need as a patient for, you know, maybe if you're specifically looking to have amenorrhea, which is again, another thing that can happen with IUDs, like our other progestin-only options, then you can maybe have an increase in size, and that increase in size might be a little bit uncomfortable. So again, having the conversations and just forewarning patients that that is a consideration for whichever agent they're going to go forward with. The other thing I find interesting about, especially the hormonal IUDs, is that the durations of how long they're good for and how long they're able to be inserted before they need to be removed and replaced is different dependent on the option that you choose. And so Mirena has a little bit of a longer one compared to maybe like Skylena or Kylena and Skyla. But I think the US has gotten a little bit better about this over the years. It used to be that Europe had like a lot longer durations that they were approved for versus the US. So at one point, the Mirena was only approved for, I want to say like 5 years, but in Europe, it was approved for like 8 years, 9 years. But I think we've gotten a little bit better. So I think a lot of the packaging has been updated in these IUDs to make them to be able to stay in for longer. Now the copper IUD. That is our non-hormonal IUD option. And so this is a great option. I love that it exists because it's our longest lasting one. It lasts for 10 years. In some European countries, it can last even longer depending upon their labeling. But this is a really great option for women who, let's say, can't have estrogen. So they have a history of DVTs. I had a pharmacist that I knew when I was in pharmacy school. She actually had a DVT in her 20s. Provoked by being on hormonal contraception that had estrogen in it. So now the copper IUD was like her only option. And she loves it. She swears by it. I was like, go you, I love that for you. But it works a little bit different mechanistically because it doesn't have hormones in it. So really it works by inducing almost an inflammatory reaction within the endometrium. And that interferes with the sperm's motility and also their viability within the area. So it works a little bit differently because it doesn't have any of the active ingredients in it. It's non-hormonal. So I just find it interesting. So again, with that inflammation kind of mechanism and then also the physical barrier, the IUD itself in that area is placing, I just find it so interesting. But for some people, this can actually increase their menstrual blood flow. So you can have more bleeding with your menstrual cycles. So for a lot of women, that's not something that they want to do. But over time, like our progestin options, it could completely take away your period. But you just have to get through the rough period to get to that point where maybe it does take it away. So in the beginning, you can actually have a lot of like increased bleeding. Again, just like points to be aware of. And then the biggest thing we talked about size, the copper IUD is the biggest one. it's 36 millimeters. So we had like 30, 32, and 36. So physically, it is the biggest one. So if you have a patient who, again, has never had children before, it may be more of a painful insertion process. This is also a hot topic in women's health about how can we decrease the pain and in the uncomfortableness of an IUD insertion process. A lot of times they will recommend girls be on their periods when they go in for the insertion process because your cervix is a little bit softer, so it might be a little bit less uncomfortable. But most of the time they tell you pop 4 ibuprofen before you come in, and that's it. And for some people, it's just not enough. It's extremely, extremely uncomfortable. So there's a lot of conversation in the OBGYN community about offering sedation for these procedures. Even, offering somebody maybe like a benzodiazepine, offering something else, more options. I always found it crazy when I was working in like the children's hospital to find out a lot of women give birth and then they're offered like Tylenol and ibuprofen and they're sent home and that's it. And I'm like, this is insane. And so I think there's more conversations and more studies happening about providing better pre-medications for IUD insertion processes to better support patients during those times.
Yeah, that's wild to hear that. 3 things that I thought of. The horror stories I've heard with the IUDs as well. Just like I've heard multiple horror stories, and personally, that's not a route that I would go down, but I'm sure some people swear by it. And if that's great for you, I love that for you, whoever you are. And then I don't know if you feel this way, but does the shape of the T with the Tesla remind you of these IUDs?
Oh, that's
when
funny.
I saw it.
No, I haven't thought about that, but that's interesting. Yeah, they do kind of look similar.
Yeah, the first time I ever saw it, I was like, oh, that's funny. And then that's all I could see when I saw it. But then the last question I had for you is the copper option sounds really great because it's the most effective. It can last so long based on what you need, however long you want it. But, how long is that terrible period where you can have an increase in your menstrual flow and you have to get through this and then to where it could potentially go to not having a period anymore? What do you know about how long that period could last on average? Or, I'm sure it depends on the patient.
Yeah, I mean, everybody's a little bit different, right? So I think it's up to 60% of women at some point will completely have their cycle go away. But normally it takes probably like a solid year. And I know that just from patients I've talked to, people I know personally who have had the copper IUD or any IUD for that matter. It could take some time. And so that first couple of months can be kind of rough. And some people, that's why they get it inserted. And then a couple months go by and they're like, take it out. I can't do this. And I've had that before with some people that I know. It's not the best option for some people. And that's why I love women's health and contraception as a space, is because we have gone from our moms, our grandmothers, maybe only having the pill as an option, right? And even if they could get a hold of that, to now where we have 10 plus options for us that fit a multitude of needs for a multitude of reasons beyond just like pregnancy prevention. And I just find it so interesting that as a patient, like if one thing doesn't work, you have options. And that's not common in medicine all the time. Like if one thing doesn't work, you have other options. And with this, you do, and you can really change the formulation and the particular hormones that you have. And of course, this requires a lot of dependence on like your healthcare provider and your healthcare team to really have those conversations and be able to have people to sit down with you and go through the options and what the differences are. And again, that's why I feel very inspired as a pharmacist in this space, is because a lot of times our health care system is just overrun and there's not a lot of time and space provided to a patient to be able to sit and ask the questions. And as a pharmacist, that's my goal, is to give you that space, to give you the opportunity to ask the questions and get the attention you deserve as a patient. And because this does take a lot of time to go through, there's a lot of ins and outs and differences and balancing of hormones and all of that stuff. And so being able to provide that to patients has been something important to me and why I really enjoy the space.
That's awesome. And it's definitely evident in you speaking about this topic that you're very passionate about it. And this isn't a sexy topic, if you will, but it's so important to, like you said, bring this to the forefront of our profession and try to advocate for, like you said, getting more options to help with pain with the IUD insertion process, or just bringing things to light and talking about it so we can progress our women's health and our ability for, better for our patients, because it needs to be talked about. And if it's not a sexy topic, we need to make it fun so that people it can be at the forefront of the minds, so we change, practice. So that's great. Okay, now we're going to talk about common misconceptions with hormonal contraception or contraception in general. Some rapid fire on you, Morgan. Is that cool?
That's cool.
Okay. First up, who should avoid hormonal contraceptives?
So we covered this a little bit throughout the podcast today, but I don't think there's necessarily, one thing that should be avoided, or one product that should be avoided, rather. It's more of what the components are, right? So we talked about estrogen as the primary concern if you're choosing that option. And so we have options that don't have estrogen in them. And then we have our options like the copper IUD that have no hormones in them at all. And so really estrogen is the bigger player that we're concerned about for all the reasons that we listed today. So people who are more at risk for blood clots, definitely if you've had a blood clot, DVT, PE, anything like that in the past, stay away from the estrogen containing products, please and thank you. But then again, just considering risk versus benefits of estrogen containing products if you have other risk factors. So typically those risk factors include anybody who's a smoker over 35, or they have a cardiac history themselves. So just, again, having those conversations with a pharmacist or another healthcare provider to really assess what your risk factors are, and then any options that are going to be off limits to you.
Great answer. My next question is, and this is something I get a lot from patients when they ask you, does long-term birth control use impact a patient's fertility?
No. I think this has become more of a conversation, especially in our generation, of people who maybe started a contraceptive option very early in life for non-pregnancy preventing reasons. But most of our options, you can actually return to your normal fertility very quickly, probably within a couple of days, with the exception of the one thing we talked about, which is Depo. Depo does take a prolonged amount of time to return to your baseline fertility, but it in no way impacts your fertility. So it just takes a little bit longer for everything to kind of reset with the Depo shot, but in no way decreases your fertility for being on birth control for an extended period of time.
Awesome. That's good to know and great information for our patients. Next question. Do I need to take a break from using hormonal contraception?
Again, another question, especially with people who have been on it since, their adolescence. So generally, no, the answer is no. What I will say is there's a lot of patients who your body is not the same as it was when you were 14, 15, 16, 17, years old, and you're maybe like late 20s. And so the option that worked for you when you were in your adolescence is probably not going to be the same option that works for you in your mid to late 20s. And so I think it's very common for people to be on one option in their adolescence, and then they change to a different option, whether that's because they need a change in dosing or they just want a different option. So again, a lot of people start with the pill, and then they either want a different balance of hormones, or they just want something that's not the pill anymore, so they switch to something else. But as a whole, being on it for an extended period of time, you don't really need a break.
Awesome. Next question. Can contraception protect against sexually transmitted infections or STIs?
Absolutely not. Do not believe that. It is only good for preventing pregnancy. So if you are with a new partner, if you are with someone who is not clear of their STI status, absolutely use other barrier methods such as condoms to protect yourself. It does not protect against anything other than preventing pregnancy.
Amen. Next, what should a patient do if they miss a dose of their contraceptive pill?
Yeah, so this is a common question. Normally, there's some fine print on the back of your box. Not everybody keeps the box that the pills come in, but it's a little bit different for each individual pill that you're choosing. So we talked about like the mini pill. It has a lot shorter of a window before it's considered a missed dose. And with that one, they recommend usually about like 72 hours after that technical missed dose that you use a backup method like condoms to protect yourself from having an unplanned pregnancy. But then generally with our like combination options, it's just about taking it as soon as you remember that you've missed a dose, whether that's in the morning or whatnot. And then if you missed at least 1 or 2 doses, that's when they really recommend for the next like 72 hours or even sometimes up to a week using a backup option such as like condoms as a barrier method. But always just looking into what particular pill option you're using and then consulting a pharmacist or another healthcare provider to make sure that you're following the instructions.
Perfect. Great points there. Next, is it safe to use contraception immediately after childbirth? I know there are some recommendations where if you're not at increased risk, you should wait like 3 weeks before you start back, just because if you're not at increased risk of clotting, because you're in a hypercoagulable state there and we're worried about clotting. And then sometimes if they're a high risk patient, you would push it out to 6 weeks. So tell us your thoughts there.
Yeah. And again, to your point, like every patient is different. So all these things that we talked about are in conjunction with having a collaborative discussion with your provider and really talking about your specific situation and what's going to be best for you. Also thinking about things like breastfeeding. If a patient is breastfeeding, so our progestin-only options are going to be less affecting on a person's milk supply if they're choosing to breastfeed. So that's a consideration as well. I actually did a little bit of research while I was in residency about immediately after childbirth inserting IUDs and the expulsion rates of that, which I find interesting because there's this conversation about when do you start birth control after having a child, because sometimes when a patient leaves the hospital, their access to care post having a baby is severely decreased, not only one because of having to care for that child and then their ability to, go to their own doctor's appointments post having a baby, but then other access issues that might happen in more different like socioeconomic patient populations. And so I read this one particular study when I was in residency about, trying to avoid that. So right after, probably like 48 hours after somebody's had a baby, inserting an IUD so that they leave the hospital already done with an option. Now, what that study found is that a lot of the expulsion rates were pretty high. So the spontaneous, like the IUD would just be like, nope, I'm out. And because you just had a baby. So everything's a little bit different down there. Typically, the OBGYNs after having a baby don't recommend anything being inserted there for about like 6 weeks anyways. So the thought of having an IUD placed that early on after having a child, again, everybody's a little bit different. So there are options after somebody has a child, then the timing of that is going to be a little bit different for everyone.
Great. That was a great discussion. Okay, if you had to give us a summary of the key points you discussed today, kind of recapping the different types of contraception we've discussed and emphasizing important factors when choosing a patient-specific option, give us a rundown of that.
Yeah, I think the biggest thing is kind of looking at the kind of categories of your options. You have combination, which contains estrogen, so plus or minus if you can even have that, or if that's a good option for you. You have the progestin-only option, which takes away the estrogen if that's something that you're concerned about. And then you have non-hormonal, such as the copper IUD. If you want no hormones, but maybe you're scared of an IUD, that's a conversation that you can have. But really, when it comes to the combination, it's again a balance of those hormones and different doses. You could be more flexible with those with a pill versus a patch or a ring. And then the progestin-only options, you get away from the estrogen, but then maybe you have to have a little bit more of like invasive procedures with like an implant or an IUD. Or you could go with something like the mini pill, but that does require some increased adherence. And so I think the theme of today is it's great that we have options. We have so many options for women. And I love that what works for me and what works for you are going to be completely different. And what works for, Susie down the street is going to be completely different. But at least we have the options. We have all of these great advancements in women's health that have given us this. And it's really about thinking about what you want, any side effects you want to avoid, any other benefits besides pregnancy prevention that you want, as far as, controlling acne or maybe completely getting rid of your cycle. Those different options can provide those different things. And so this all requires a lot of collaboration and a lot of conversation with your provider. And so really picking a provider that's going to be open and having those conversations with you is also really important. So finding somebody that you trust and who you think is really going to listen to you and what you want, and not just give you kind of like the first thing that rolls off of their head.
Yeah, that's great. It's almost like when you have so many options to choose from, it puts you in this like analysis paralysis where you're like, I don't even know where to begin. So you going through all this was really helpful for our providers to try to help educate and get our patients where they can pick the best option for them and their needs and preferences. So thank you so much, Morgan. This has been awesome. You've made women's health very fun. And thank you to all of our listeners for our first episode of the women's health series that we're going to have. And I hope you're on board. We're going to make it so much fun, and we're going to bring all these important issues for our pharmacists and our patients. And we're really just trying to move the needle here by learning and sharing together. So please like and comment and subscribe so you never miss another episode with the Pharm So Hard Ambulatory Care podcast again. And let us know what you thought. Keep the conversation going. What questions do you have? What discussion points do you have on our conversation today? Let us know. We also have a Patreon that we're going to put the details to in the show notes, so feel free to check that out. And thank you, Morgan, for sharing your insights on hormonal contraception today. It's been an absolute pleasure interviewing you. Until next time, thanks so much for being a part of the Pharm So Hard Ambulatory Care podcast community. And don't forget to continue learning, growing, and sharing so we can continue to make a difference for our profession and our patients. Until next time, bye, fam.
So I farm so hard, the employees wanna find me, and then wanna hire me. What's 100K to a guy like me? Could you please remind me? Farm so hard, this ain't easy. Working late nights, you best believe me. My grades can only go ace. Never wanna see another B unless I'm Jay-Z. Farm so hard, let's get paid.
This is Morgan Grier.
This is Micaela Hayes, and you're listening to another episode of the Pharm So Hard Ambulatory Care podcast.